Hi, I'm Kathy Ramos, and I am an adult pulmonologist at the University of Washington. I work in both CF and lung transplant, and I have grant funding from the Cystic Fibrosis Foundation, the NIH, and the CHEST Foundation in partnership with Vertex Pharmaceuticals. Today, I will talk about the use of elexacaftor-tezacaftor-ivacator, or triple therapy, after non-lung solid organ transplant and after lung transplantation, and then summarize my thoughts. CFTR modulators after non-lung solid organ transplantation may be the least controversial of the arguments for the use of CFTR modulators after solid organ transplantation. There's growing experience across the North American CF centers, and there are several reports of liver transplant recipients or liver kidney recipients receiving triple therapy for treatment of lung disease and having significant pulmonary benefits. FDA approval was based on lung function benefits, which is directly relevant to individuals with native CF lung disease. There are some individuals post-liver transplant who have been removed from the lung transplant waiting list due to substantial improvement in their lung function on triple therapy. There are special considerations in this population, including liver toxicity, which may require increased monitoring for elevation of transaminases on triple therapy. Prescription of triple therapy requires consultation with the transplant hepatology team for patients who are post-liver transplant. There have been experiences with transplant hepatology teams requesting a delayed start to triple therapy for individuals who are experiencing complications in their liver graft. So the overwhelming experience seems to be that hepatologists are open to the use of triple therapy post-liver transplant. Drug-drug interactions may necessitate changes to the immune suppression regimen or the dose of the immune suppression medication to maintain therapeutic levels. The CFTR modulator dose for some liver recipients are reduced. And so because of liver toxicity at the standard dose, some liver transplant recipients are actually receiving doses of triple therapy that have not been studied for efficacy in randomized clinical trials. Despite this, the recommendation that I would make is to initiate CFTR modulator therapy for individuals after non-lung solid organ transplantation in close coordination with the transplant team. CFTR modulators after lung transplantation is more complex, and I want to start by briefly sharing information about lung transplant outcomes for CF recipients because it provides context for the argument to try CFTR modulators after lung transplant. As we have heard in earlier sessions today, CFTR modulators have implications for endocrine, GI, and other non-pulmonary manifestations of CF. I'll share some unpublished data related to the effects of CFTR modulators on sinus disease and highlight an NACFC poster with more details available. I will also share some unpublished data describing post-transplant survival among individuals with CF by CFTR genotype from analyses of a merged dataset containing records from the CF Foundation Patient Registry and the UNOS OPTN Registry. I'll highlight an NACFC poster with more details available for that study. Finally, I will describe the post-lung transplant experience with triple therapy in the CF Lung Transplant Consortium. These data are preliminary and are being captured through the electronic health records at 15 sites participating in the CF Foundation's CF Lung Transplant Consortium. So the new 2020 ISHLT registry report was not yet available when I created these slides in September. The annual report is always released right before NACFC, so there may be updated survival estimates by the time of the talk. This figure shows the international survival estimates for adults after lung transplantation by diagnosis. Note that the dates include transplants performed in the 1990s, and that survival after lung transplant has improved significantly over that period of time. For adults with CF, the median survival after lung transplantation is 9.9 years, compared to 6 years for COPD and 5.2 years for idiopathic pulmonary fibrosis. The 1-year conditional median survival for CF is the estimate of median survival for those who live at least 1 year post-transplant is 12.4 years, and more than 25% of CF recipients are alive at 20 years post-transplant. I want to discuss the cause of death after lung transplantation. So chronic lung allograft dysfunction is sometimes referred to as chronic rejection, and it's an umbrella term defined by a substantial and persistent decline by at least 20% in the measured FEV1 value from baseline. CLAD can present as either a predominantly obstructive ventilatory pattern, a restrictive pattern, or a mixed obstructive and restrictive pattern that's not explained by other conditions. CLAD and graft failure are the most frequent causes of death for individuals living more than 1 year post-lung transplant. This figure shows that by 5.5 years post-transplant, approximately 50% or just more than 50% of CF lung transplant recipients have obstructive CLAD. Infection and malignancy are also important causes of death after lung transplant. So acute cellular rejection is the biggest risk factor for chronic lung allograft dysfunction, or CLAD. Antibody-mediated rejection is increasingly recognized as a risk factor for CLAD. Non-immune causes of epithelial injury and subsequent CLAD include acute infections, specifically with viruses, GERD, where a growing body of literature shows an association with CLAD, and anti-reflux surgery may improve FEV1 or prevent the progression of CLAD, chronic sinus disease, and chronic airway infection. Chronic sinus disease is thought to be a risk factor for colonization of the lung allograft with Pseudomonas, and Pseudomonas colonization in the lung allograft has been linked to increased risk for positive donor-specific antibodies, antibody-mediated rejection, and CLAD. And even air pollution has been linked with CLAD. There is a focus on the role of inflammation in CLAD, and multiple inflammatory markers have been associated with lung injury in the lung allograft. CF-related sinus disease post-lung transplant is important, and studies show that the sinuses act as a reservoir for bacterial pathogens in the CF lung transplant recipients. Surgical treatment of sinus disease has been associated with decreased risk of pulmonary infections. There have been some conflicting results in small studies of sinus surgery for chronic rhinosinusitis and the effect on lung transplant outcomes, but it's important to recognize that surgical techniques have evolved over time, and newer, more aggressive endoscopic surgical techniques are thought to be more effective. One study showed that for patients in whom sinus pathogens were eradicated, there was an improvement in 5-year survival and reduced rates of CLAD. A separate study showed that CFTR modulator therapy, specifically ivacaftor, may enhance fluoroquinolone activity against Pseudomonas. The CF-related sinus disease on triple therapy is what I'm going to talk about here. And in a single center pre and post study designed with 43 patients with CF without lung transplant, Dr. Domingo and colleagues evaluated the effect of triple therapy on the sinonasal outcome test, or SNOT-22. It was recently published in JCF, and there was a statistically significant and clinically meaningful decrease in the SNOT-22, which improved from 34 to 24 over 3 months. In a separate study at 2 sites with 33 patients, which is presented in an NACFC abstract this year by Dr. Stapleton and colleagues, there was also a statistically significant and clinically meaningful improvement in sinus symptoms rated by SNOT-22 after triple therapy initiation, and the benefit was sustained for at least 6 months. This study also evaluated endoscopic sinus exams and olfaction, with data collection ongoing for those endpoints. CF lung transplant recipients have an increased risk of malignancy, including colon cancer and other GI malignancies, and post-transplant lymphoproliferative disorder, which is related to the Epstein-Barr virus. CFTR may have a role in tumor suppression across a variety of tumor types. Loss of CFTR function leads to disruptions in cellular processes, some of which have been associated with carcinogenesis. How restoration of CFTR function could suppress post-transplant malignancy is unclear, but it warrants investigation. This study by Dr. Clausen and colleagues is presented in an NACFC poster this year. The study used a merged data set containing records from the CF Foundation Patient Registry and the UNOS OPTN Registry, and included lung transplants between 2005 and 2017 in the United States. CFTR genotype is associated with phenotype and disease severity, as we know, and in this study, high-risk genotypes were classified if 2 mutations were present from classes 1 to 3, and low-risk classifications were given if there was at least 1 mutation from class 4 or 5. And mutations were unclassified for all other categorizations. Patients with unknown genotype were excluded from these analyses. This figure shows the Kaplan-Meier estimate for survival without retransplant. And as you can see, the CFTR genotype is associated with post-transplant survival, with the low-risk genotype shown in blue having a higher survival probability over time. After adjusting for potential confounders, the recipients with a low-risk genotype had a 37% lower risk of death or retransplant compared to those with a high-risk genotype. Patients with the high-risk CFTR mutations have worsened survival after transplant compared to the low-risk genotypes, suggesting a potential role for CFTR modulator therapy for management of the extrapulmonary manifestations of CF after lung transplant. We're performing an electronic health record-based cohort study with patients eligible from October 2019 to September 2020 at 15 CF Foundation CF Lung Transplant Consortium sites to identify CF lung transplant recipients who have been prescribed triple therapy after lung transplantation. The eligible patients are identified through the transplant and CF physicians at the LTC sites. There's been report of approximately 100 patients across the 15 centers who have been prescribed Trikafta after lung transplant. Only 4 out of the 15 sites report 0 patients on Trikafta, one of which is the site in Toronto where Trikafta is not yet approved. And there's a wide range in the number of patients at the individual sites and variability in practice. Currently, we have data on 44 patients across the 5 sites, and though the data entry is incomplete for some of the patients, we do know that of these 44 patients, 4 patients did not actually take the triple therapy, 1 because there was no insurance approval, 2 because of concerns about the required safety labs during COVID-19, and 1 person actually died before the medication was delivered to her home. And so we have more details about these 40 patients who are on triple therapy, and what they found was that immunosuppression management has been challenging for only 1 of the 40 patients who started triple therapy, and in that case, the tacrolimus level was very variable and required close follow-up. For the majority of other patients, there were dose adjustments to the immunosuppression regimen, but they were straightforward and easy to correct. Identifying the indications for prescribing triple therapy was a primary objective for this study, and we found that the most commonly reported conditions that factored into prescribing triple therapy was sinus disease, followed by GI symptoms, diabetes, and low BMI. Interestingly, for some patients, CLAD and considering retransplant were also relevant factors, most often in combination with sinus disease or low BMI. There is an association of triple therapy with increased BMI, though the BMI data is limited in this cohort because of COVID-19 and fewer in-person visits. All patients who were prescribed triple therapy who had BMI data did have an increase in their BMI on average. And it was especially noticeable for people who had an initial BMI that was less than 18.5 or where low BMI was reported as a factor for prescribing triple therapy. In those patients where low BMI was a factor or their BMI was low, their BMI increased a significant amount more than all patients combined. Unfortunately, we don't have objective measures for change in sinus symptoms or GI symptoms in the current consortium cohort. And the follow-up time since starting triple therapy is pretty limited in many cases, but there have been no reported episodes of acute cellular rejection in the 40 patients in this cohort on triple therapy, which is reassuring. We're still gathering the diabetes data, including hemoglobin A1C and random glucose levels. And I'll mention it here and I'll come back to it again. I think we need a randomized controlled trial to evaluate the potential benefits and harms of CFTR modulators post-transplant, because these observational data are limited by important biases like indication bias and survivorship bias. So just to touch on the CFTR correction and lung transplant biologic plausibility, CLAD and malignancy are important post-lung transplant causes of death for CF recipients. Extrapulmonary manifestations of CF are implicated as causes for CLAD, including chronic rhinosinusitis leading to chronic airway infection and GERD. Inflammation in the lung allograft is implicated as a cause of CLAD, and inflammatory pathways are not normal in patients with CF. And CFTR dysfunction increases the risk of malignancy. So in summary, for non-lung solid organ transplant patients, triple therapy or ivacaftor should be used in coordination with the transplant team due to the drug-drug interactions and the implications for immunosuppression dosing, as well as potential toxicity to the liver allograft specifically. For CF lung transplant recipients, extrapulmonary manifestations of CF may contribute to the development of CLAD and worsen post-transplant survival. And finally, triple therapy should be studied in a randomized controlled trial to determine the benefits and harms in the lung transplant population. Thank you for attending this session, and I hope you will join us for the live panel discussion during NACFC.
Hello, my name is Erin Lowry, and I'm an associate professor of medicine and pediatrics. I'm currently in a period of transition. At the time of this recording, I am at Loyola University Medical Center in Maywood, Illinois. But by the time of NACFC, I will be at University of Wisconsin in Madison. I'm a cystic fibrosis doctor and a transplant pulmonologist. And I would like to thank the organizers of this symposium for inviting me to speak to you about a hot topic, CFTR modulator use after transplant. I will be arguing that CFTR modulators should not be used in all patients with CF following transplantation. I have no relevant disclosures related to this presentation, but I would like to disclose that I have started patients on CFTR modulators post-lung transplant, post-liver transplant, and with advanced lung disease. So my first argument is that CFTR modulators were approved for CF pulmonary disease. The randomized controlled trials of CFTR modulators were performed in CF patients with normal to moderately impaired lung function from CF pulmonary disease. No transplant patients were included in any of the randomized controlled trials looking at CFTR modulator use. The primary outcome in the randomized controlled trials were improvement in lung function. It should go without saying, but after lung transplant, CF patients have lungs from non-CF recipients. Therefore, the intended therapeutic target of these drugs, CF pulmonary CFTR, is no longer present. As you can see, at transplant, we take out the lungs with dysfunctional CFTR and we put in new lungs with functional CFTR. So in preparing for this talk, I wondered, is there any evidence of beneficial use of CFTR modulators in transplant recipients? And what I found was nothing. So we really don't know what CFTR modules in lung transplant recipients are doing, if anything, and is there any benefit at all, and what is that benefit? And I think this is the biggest and most obvious reason why not to use these drugs in CF patients following transplantation. My next argument is that CFTR modulators might have an unintended adverse effect in patients who have transplant. CFTR modulators might impact CF patients differently in patients who are in different disease states. Different populations of CF patients might experience these drugs differently. For example, when lumacaftor-ivacator came out, there was a phase 3B open label investigation in CF patients with advanced lung disease. And these patients had an increase in serious adverse reactions, particularly when compared with those with normal to moderately impaired lung function. And so we can't be assured that patients with lung transplant are going to experience the drugs, particularly the adverse reactions, the same way that patients without lung transplant are. And so without studying this, we could unintentionally be causing harm. We know that CFTR is present on immune cells. CFTR is located on macrophages, neutrophils, and lymphocytes. We know that we've known this, that their immune cell function is not normal, yet patients with CF have the best survival compared to other lung transplant recipient groups following lung transplant. And here is a slide from the International Society of Heart and Lung Transplant that compares pre-transplant pulmonary disease and their outcomes following transplant. You can see CF patients are in purple, and across the top have by far the best survival following lung transplant, despite that CFTR dysfunction that is present on their immune cells. In general, immunosuppression following lung transplant works to decrease the function and activation of immune cells, particularly lymphocytes, to decrease rejection. Improving the function of immune cells following transplant could have unintended detrimental impacts. And the major question here is it better to have a lung transplant with CFTR dysfunction in immune cells, what we currently have, compared to a lung transplant with improved or normal immune cellular function due to CFTR modulation? We really don't know, and we don't know what CFTR modules are going to do to the immune system in those patients who are post-lung transplant. Therefore, we should proceed with caution. What about lungs that are wild type? We know that ivacaftor potentiates wild type CFTR. We also know that at least 10 million people in the US carry at least one CF mutation. If a CF patient happens to receive lungs from a CF carrier, what effect does, if they're placed on a CFTR modulator with ivacaftor, would that CFTR potentiation cause any effects in the transplanted allograft? How would that impact the development of chronic lung allograft dysfunction, or CLAD, otherwise known as chronic rejection, or ultimately their survival following transplant? These are questions that we just don't have answers to. CFTR modulators also affect mental health. So use of CFTR modulators in some CF patients has worsened anxiety or depressions in some preliminary reports. This is thought to be multifactorial due to the drug-drug interaction between the CFTR modulator and perhaps SSRIs, which are used to treat anxiety and depression. There might also be a direct effect of the modulators on the brain tissue, which also contains CFTR as well. Following lung transplant, unfortunately, anxiety and depression rates have remained high. So in this investigation cited here, they had interviewed 178 patients, lung transplant patients, in various time intervals following transplant, 2 months, 4 months, 6 months following transplant, and gave them testing to determine whether there was depression or anxiety present. You can see almost a third of those patients had depression. And so starting a CFTR modulator in this patient population might destabilize some anxiety or depression in this patient population. We just don't have any investigations to tell us how it's going to go for them. We do have the Cystic Fibrosis Lung Transplant Consortium and their members who have started Trikafta on a few of the patients following lung transplant. And I would like to thank Dr. Ramos for graciously lending this slide to me of the preliminary data. And you can see of the member centers in the consortium, there was a combined about 40 patients who started on Trikafta after transplant, 17 of which stopped. So almost 40% of the patients stopped Trikafta due to adverse drug reactions. And so that should give us some pause. CFTR modulators have potentially serious drug interactions following lung transplant. And so following lung transplant, patients are placed on a polypharmacy of medications. And these include at least 3 immunosuppression drugs to prevent rejection, 3 antimicrobial agents to prevent infection. And oftentimes these drugs have side effects that cause other medical conditions such as diabetes, hypertension, arrhythmias, anxiety, depression. And so now you need more medication to treat those side effects. So you're already in a state of polypharmacy where the patients following lung transplant are taking a lot of medications. CFTR modulators would only contribute to the polypharmacy and lead to more drug-drug interactions, which could lead to more adverse effects. So the majority of drug activity and interactions are due to cytochrome P450 enzymes and can result in either induction or inhibition of one of the subgroup enzymes. So for CFTR modulators, they use the cytochrome P450 system. So looking specifically at Trikafta, Trikafta is a substrate of cytochrome P3A. The elexacaftor-tezacaftor specifically inhibits several of the subgroup enzymes, and the ivacator inhibits additional cytochrome P450 subgroup enzymes as well. So trying to put this all together, you can see that there is the potential for many drug-drug interactions. Most specifically, I want to point out that the antifungals, which is very commonly used following lung transplant, specifically in the first 6 months, are strong cytochrome P3A inhibitors, and therefore when they're used with a drug like Trikafta, this would increase the exposure of elexacaftor-tezacaftor by 4 to 4.5 fold, and ivacaftor by 15.5 fold, and therefore it's not recommended that you use Trikafta and the antifungals at the same time. You also have to be careful with other drugs such as anti-seizure medications, some antibiotics, warfarin, oral anti-diabetic drugs, and very importantly, some of our immunosuppression. So calcineurin inhibitors such as tacrolimus and cyclosporin, as well as mTOR inhibitors, everolimus and sirolimus. My final argument is that CFTR modulators are expensive, and I think you all know that. But what is our responsibilities as care providers in terms of the greater healthcare system? The cost of a bilateral lung transplant in the United States is anywhere from $300,000 to $500,000 if you account for the transplant hospitalization and the post-transplant care for about 1 year. You can see in this investigation, they looked at lung allocation score and cost of transplant. And as the lung allocation score increased, the cost went up. If you add CFTR modulators into the cost, that's going to be over $300,000 annually, in addition to the lung transplant costs. Additionally, if you look at the number of CF patients who received lung transplants while receiving Medicaid or Medicare, our United States governmental health care, you can see almost 40% of the CF patients were on the government plans. Therefore, the costs both of lung transplant as well as CFTR modulators are being passed on to the taxpayers and the US government. So we do need to be careful stewards of our healthcare resources. In preparing for this talk today, I did talk with several of my colleagues to see why they used CFTR modulators following transplant. The most common reason cited was CF chronic rhinosinusitis. My response to that specific indication is that we have therapies that control sinus disease in CF patients, including nasal rinses, topical steroids, topical Dornase, and topical antibiotics. And for the most part, these therapies do work if the patients are using them, particularly in the post-transplant setting. Oftentimes, following transplant, the immunosuppression actually calms down some of the inflammation in the sinuses. So sometimes their sinuses actually get a little bit better following transplant. And the most often cited reason for using a modulator is that we will potentially be decreasing graft colonization with CF-specific organisms. My response to that is we don't know that because we haven't studied it yet. And we don't even know that recolonization with CF-specific organisms is necessarily a bad thing. There are some studies that indicate that when the lung allograft is recolonized with CF-specific organisms, particularly if from the sinuses or from the trachea that is left in CF patients at transplant, that there is no increased risk for chronic lung allograft dysfunction or chronic rejection, which is our ultimate outcome. So we really are left with more questions than answers in regards to rhinosinusitis. Turning now to GI symptoms, which was cited as well for use of CFTR modulators. Pancreatitis can rarely happen after transplant, particularly in pancreatic sufficient CF patients. It is very, very rare to have this situation particularly be a recurrent problem after transplant. Diose does occur after transplant. It's a known complication, and it's one that can be avoided with a proactive approach and careful attention to an increased bowel regimen. And so adding a very expensive modulator just to prevent diose does not seem fiscally responsible. Some of my colleagues have cited that there would be improvements in nutrition and weight gain. In the post-transplant population, this isn't so much of a concern. Most CF patients gain weight following lung transplant, and really it's due to several things. The pulmonary demands have decreased substantially, so they're not burning as many calories. They feel better, they're healthier, they're able to eat more, and the medications that they're receiving for transplant also cause weight gain and increased appetite. So usually weight gain is not a tremendous problem, particularly once they reach their goal weight. And finally, I've heard some suggestion that modulators might help with CF-related diabetes. And in those with lung transplant, the diabetes that we see after transplant, it's often a combination of CF-related diabetes as well as post-transplant diabetes, which is induced by corticosteroids and the immunosuppression agents. And so it would be surprising if a modulator would help in this scenario. I want to briefly just touch on CFTR modulator use following liver transplant. We really don't know anything except what has been shared anecdotally. Obviously, this population would benefit more from modulator use because they do have CF pulmonary disease. Modulator use is not recommended if there is advanced hepatic impairment. If you have moderate impairment of liver function, you can start CFTR modulators with dose reduction and careful monitoring of liver function. The CFTR modulators can affect the metabolism of rejection medications such as calcium inhibitors, as I mentioned earlier. So you have to monitor those drug levels carefully. And serious adverse reactions, including transaminitis, could theoretically limit the use in this population. But careful coordination and co-management with transplant hepatology is crucial. So in conclusion, CFTR modulators were approved for CF pulmonary disease. Lung transplant patients have normal CFTR function in their transplanted lung. CFTR modulators in transplant patients may have unintended adverse side effects, so you do have to proceed with caution. There is the potential for serious drug interactions, so working closely with a pharmacist who understands all of the various interactions is imperative. CFTR modulators are expensive, so consider the societal impact of cost burden to the healthcare system versus benefit to the individual in someone who no longer has CF pulmonary disease. So my recommendation would be that CFTR modulators should not be prescribed to every patient with CF following transplant. CFTR modulators should not be prescribed to CF patients in the first 6 months following transplant due to serious drug interactions with antifungal therapy. CFTR modulators should only be considered in post-lung transplant patients with refractory nutrition, GI, or sinus issues, not otherwise controlled with usual medical therapy. And so these would be the patients that I would selectively target for a trial of CFTR modulators to help with these CF complications. In other solid organ transplant recipients, such as liver transplant, CFTR modulators should be considered in order to improve and optimize their lung function. So thanks for listening. I'd be happy to entertain any questions during the live Q&A panel discussion during NACFC. Thanks.
Good afternoon, everyone. Thank you so much for inviting me to join this year's conference and to speak at this particular symposium. So my name is Christopher Richards. I am an adult pulmonary and critical care physician at Massachusetts General, and I'm one of the primary CF providers at our center. Today, I'm going to be taking the position in this discussion that Trikafta should be used in very mild disease, or even if there is no demonstrable benefit. So before we get started, I do want to just say that I have nothing to disclose as it relates to this talk, and I want to invite everyone to submit questions to the Q&A forum. I'm going to be checking in on this throughout the conference, and we'll be using that as a source of input for our live panel discussion later on. I also want to invite anyone who wishes to continue this conversation to reach out to me in one of the networking forums or by email. I'm happy to talk more about this. So I am of the strong opinion that Trikafta should be started for all patients who qualify. And when Trikafta first came out last year, my assumption, probably naively, was that all patients who qualified would be wanting to start the medication right away. And by and large, that was true. We had many patients calling the clinic the day after the announcement came, wanting to get started on the drug. However, definitely a good group of patients who had their reservations and who would ask, why would I start this new medicine? I feel fine. My lung testing is fine. Why would I do this? So the question is, well, how much does this come up? The answer is all the time. There's plenty of patients who find themselves in this situation. I'm not that symptomatic. I don't know if there's anything that's going to really happen if I take it. Why would I do it? So just a kind of an estimate of how many patients nationally may be falling into this group. We've got 31,000 patients in the US, and about 13% of them, when they're diagnosed either by DNA analysis or with family history, they're asymptomatic at that time. Further, We know that there are genotypes that are associated with more mild phenotype. So in the registry, you look at some of these mutations that would be amenable to Trikafta, and you can see that R117H, A455E, these are mutations that lead to less obstructive disease, preserved FEV1, and significantly different than when you compare it to 508 homozygote. Additionally, you don't. Another measurement of lung function is the amount of pseudomonal colonization. So there are patients asymptomatic when they're diagnosed, have lower severity phenotypes, and they may fall into this place of asking, well, what am I doing with this drug? So what do I say? It took me a little while to say this in a convincing way, but cystic fibrosis is a progressive illness. We know this. We know that the longer patients live with CF, that there is a decline in lung function, the complications of the illness build up, and there is a clinical decline, and clinical progression rather. If you look at FEV1 and you look at trends over time by birth cohort, those people born in the late 1980s, by the time they're in their late 20s, early 30s, FEV1 has dropped down to 70% predicted. You look at all the way up until those patients born in the early 2010s, there has been a consistent improvement in that rate of decline. And here we are, patients born in the early 2010s, approaching age 9 in 2018. These are the people who would have had the opportunity to start CFTR modifiers early, and there's a leveling out. This decline in FEV1 is flattening, and it is very notable when you compare that to people born 25, 30 years ago. The other thing to know is that spirometry isn't everything, right? Spirometry is great. You can do it in the office. We could even do it at home with the small devices. It's fast, it's reliable, it's reproducible, but it can miss things. And so how often do the patients come in? How often do you experience that it's just a little bit harder to exercise? You just feel a little bit more short of breath, going upstairs, doing things that you used to do without issue. How often does that happen? You come into clinic, you do your breathing test, and the FEV1's fine. Everything comes out normal. Well, that doesn't mean that you're just out of shape. It could mean very well. I mean, it means that the spirometer isn't the end all of everything. So we have other ways of measuring it. We know that there are other methods of looking at obstruction that pick things up the spirometer doesn't. Lung clearance index, multiple breath washouts. These are tests that we know to be maybe a little bit more sensitive than spirometry, but they're pretty well limited to research settings. They're not available at all centers. It requires specialized equipment and the like. The other thing we know is that these functional studies, spirometry included, may well underestimate the degree of bronchiectasis that you see on a CT scan. I'm loath to order an annual CT on my patients. It's just, could wind up with hundreds of these things over the course of your life if every year you're getting a CT scan at the least. So we reserve that, and by reserving it, we may well be missing smaller changes that the spirometry doesn't have. So just because the testing all says normal on the printout doesn't mean that's the case when you dig a little bit deeper. The other thing to know is that we've hinted at this already, CFTR modifiers change the course of CF, all right? And this is, we're just getting better and better data to support this. So this is a study, Zwicky et al., where they were looking at, wanted to see, well, for patients who started ivacaftor, those with the G551D mutation, what was their lung function? What was that rate of decline? What was that change 1 year, 2 years, 3 years out from starting the medication? Little bit tricky to do, right? Because by 3 years, most of the patients in the registry who could take ivacaftor had started ivacaftor. So there wasn't much of a comparison group. However, you can make inferences from people with 508, 2 copies of 508, right? We know they weren't being treated with a CFTR modifier at the time. That's a pretty good estimate of lung function decline compared to those on ivacaftor, and you can see significant reduction in that rate of decline. It wasn't just in lung function; it's true for BMI as well. So BMI was stable, remained stable, and significantly more so than for patients who had 508 homozygote and were not on a CFTR modifier. All right. The other thing is, you can look back. You can do reanalysis of the big pivotal trials. You go back to the Orkambi trial. You stratify patients based on high versus low lung function, and it didn't matter. The effect of Orkambi was seen in those patients with high lung function, those patients with low lung function. So it's not as if those patients, the whole benefit was being driven by the people with more progressed disease. No, patients who had relatively well-preserved spirometry also benefited from this. Okay, so mild disease, you're seeing benefit from these drugs. And we have real-world experience at this point, right? This isn't just something you have to look to the studies. You look at 5-year outcomes in the US, UK registries. That decline in FEV1 for those patients on ivacaftor is markedly reduced than those patients without. So these benefits are significant. They are sustained. Okay, so a progressive illness. We know FEV1 to drop. We know spirometry to get worse over time. These drugs can change that pathway with very good evidence. The other thing is that lung function testing is not everything, right? Coming in the clinic, doing a breathing test, seeing some numbers, that's something, but it's not everything, right? Exacerbations are a major part of life when you have CF. Exacerbations mean more antibiotics. Exacerbations mean time in the hospital. It means feeling unwell. It means backing off from your responsibilities to family, school, work, what have you. Exacerbations are major consequence of the illness. And these modifiers reduce those exacerbations. What's more so is that the more exacerbations you have, we know very well that that's connected to 5-year survival. So if you can start on Trikafta, even though you're feeling very well now, and you can cut back on those exacerbations, that's a marked improvement in quality of life, and it also bodes well for improvements down the road. So what's the downside? This is the other part of the conversation. You can point to all this information, talking about preservation of lung function, preservation of VMI, fewer exacerbations, point to all of that. And the question is, well, what's the downside? This is a new drug. I've taken I'm a little bit skeptical of starting something that just came out. I want to see how it plays out. I've taken so many drugs my entire life, I'm hesitant to start a new one. Well, so what's the downside? Side effects, okay? So in the studies, side effects were actually pretty common, but they weren't terribly severe. And in only a handful of cases, less than 1% of all the cases in the trials, were the adverse events, the side effects, so significant that a patient stopped treatment. In our experience, matches up, pretty well with what side effects were noted in trials. And, that is a couple of things commonly brought up by our patients. It's really common for patients to describe, sometimes almost immediately after taking their first dose for the next 24, 48, 72 hours, all they do is cough. I mean, it's been described to me as, I feel incredibly sick. I feel like I have a brand new infection and I am coughing up mucus that I never knew I had. I've heard one person call it the purge. And that happens. And for most people, it resolves itself after 32 hours. 72 hours. It's quite remarkable. A lot of chest tightness can accompany that, wheezing, but it's short-lived. Nausea is something that gets reported a lot. It's something that we kind of encourage people through, do a little cheerleading. I haven't heard many people at their 3-month follow-up say that it's still a major issue. Could be wrong about that, but at least that's my experience. We check LFTs, we check CKs. I think we've had 2 patients now whom we've had to hold the drug and subsequently restart because of that. So definitely there is that issue. Definitely, even if you're asymptomatic, you have to go along with the recommended testing and safety monitoring. And I think actually one of the more significant things that, again, seems to resolve itself is patients describing it's kind of vague feelings of not being as sharp, being more fatigued, kind of feeling out of it. Best description I've heard of it is kind of, I have this mental fog, just not myself. That's probably one of the more common things people have said to me. It's and it's something we say, okay, let's keep going. Just keep going, see how it goes. And again, I don't have many patients who are coming back to me at their 3-month follow-up saying, this is still going on, this is intolerable. So, yes, side effects exist. Yes, there's going to be, not everything is going to be perfect, right? And, but it is worth knowing that in general, they're mild, and in general, they're rather self-limited, okay? So here's the other thing. We really want to know how Trikafta is going to pan out, not just in the immediate months after its release, but years from now. I want to be able to take an argument to my patient who is skeptical, weary of starting the drug, or maybe who has not seen that dramatic benefit that other people on, other family members, other people on the forums have been talking about, and asking, why am I continuing? I want to be able to have something in the back of my pocket, strong evidence that says, this is what happens. And that's going to come through PROMISE. So this is it's a ongoing prospective observational trial. Patients get baseline, or recruits get baseline testing, whole series of domains, take the drug, and then multiple visits over the next 24 months. The same measurements are taken. And the idea here is to see how Trikafta changes, affects the trajectory of CF. So I think many people are aware of this trial, are familiar with it, but I point to it because I want to be able to, I'm hopeful that moving forward, I'll be able to take the findings of this study, say to someone who is having questions about whether they should continue or whether they should start, and say, this is what we know. and we know this better than with any of the other modifiers. This is what we know Trikafta will do for you over the next several years. So I think it's going to be a really important part of this conversation. So, that's where I leave my argument. I feel strongly that all the patients who qualify should be offered, for sure offered, and should have a really deep discussion with their provider about the pros and cons. I fall on the pro side of starting the drug early. It's because we know it progresses. We know that these drugs change the course of the illness, and we know pretty well that they're pretty well tolerated. And the other thing to realize is there's plenty of patients who are going to have this conversation with, so it will come up for sure. A quick thanks to the MGHCF Center, all our other physicians, our social worker, our nutritionist, our specialized practice nurse. I mean, this is just a really great group of people to work with, and a really wonderful group of patients to get to know. Thank you.
Hello, and it's a delight to take part in this virtual North American CF conference. My name is Peter Barry. I'm an adult respiratory physician based in Manchester in the United Kingdom. And I'll be talking today about Trikafta should not be used for very mild disease or if there is no demonstrable benefit. Here are my disclosures relevant to the slides. In particular, I have participated in clinical trials and worked with Vertex Pharmaceuticals. First and foremost, there's an elephant in the room, and I think we need to address it. Triple CFTR modulator therapy is obviously a huge leap forward for people with CF. It's undoubtedly highly effective, and access to these medications globally is essential for the CF community. I myself have served a PI on trials of triple CFTR modulator therapy, and I'm aware of the benefits for those involved. So therefore, when you look at the statement that I will be arguing, your reaction may be one of disbelief or shock. But I would emphasize that we're looking at very mild disease, and if there's no demonstrable benefit, and hopefully over the course of the next 18 minutes or so, your demeanor will change. Dr. Richards has argued that Trikafta should be used for very mild disease, or even if there is no demonstrable benefit. And indeed, the FDA license in the US differs from the European license, where you can treat F any, and so potentially there's a lot more patients can benefit. But that argument really is treatment based on genotype or even pre-symptomatic disease. And the argument that triple CFTR modulator therapy is actually effectively prophylactic against deterioration. I will outline that I think as physicians we have an obligation to use these medications correctly, and particularly 5 main points. The very mild disease is not associated with class 1 to 3 mutations, and the evidence for early intervention is actually restricted to this subgroup. We are in fact still limited in our ability to predict disease progression in those with milder genotypes. And therefore, we're risking over-treatment, which is not in keeping with precision medicine, alongside the real considerations of cost, risk-benefit, and equity of treatment. Because we have obligations as physicians. These 2 gentlemen, Beauchamp and Childress, wrote the book, The Principles of Biomedical Ethics. And we're all familiar with their 4 main pillars: autonomy, beneficence, non-maleficence, and justice. And 2 of those may be very relevant to this debate: beneficence, where a practitioner should act in the best interests of their patient, and justice, which is concerning the distribution of health resources. And I think we need to bear these in mind as we move forward with this talk, because there is in fact a debate in the literature. These are just a number of articles from JAMA looking at orphan drugs, thorax similarly, and there are also questions regarding personalized medicine. I think the first thing we have to address in this debate is very mild disease. This here is a picture of a sign taken in the Everglades by my brother. And what's important is that this is a straightforward sign, but when taken in context, it is probably the wrong thing, as you can see the road lined by gators here. So very mild disease, in my opinion, is not actually defined by a snapshot. It's a combination of current disease and also future disease liability. And that concept is really, really important. If we look at ivacaftor treating those infants with a gating mutation in the single phase 3 study, you can see a significant improvement in fecal elastase over the course of the study, which has been much heralded. But the majority of those infants had pancreatic insufficiency or indeed exocrine pancreatic failure. And I don't think single organ failure is consistent with very mild disease, regardless of what your lung function measures may show. And genotype is important, not just for the snapshot, but also for disease progression. This study from the ARREST-CF group looked at early structural lung disease in children with CF assessed using sequential CTs. And you can see the strongest association with progression of bronchiectasis is severe genotype. Indeed, the strongest association with progression of air trapping is also severe genotype. So that is really what suggests significant versus very mild disease. So is there evidence for a clinical response to triple CFTR modulation in very mild disease? Well, nothing published, notwithstanding the recent press release from Vertex about the 6 to 11-year-old age group. That unfortunately did not contain the data that we could, gain more information. But I would also note that this was genotypes in homozygotes and F minimal function. So is there evidence for clinical response to highly effective modulator therapy? Well, let's look at ivacaftor in children 2 to 5 years old. Again, at pancreatic insufficiency, a significant increase in fecal elastase level, but again, severe disease. Perhaps mild lung disease is the G551D patients with preserved spirometry. And you can actually have a detectable difference in LCI measures, but indeed their LCI was abnormal and detectable abnormal disease at onset. So I don't think really we can actually say, despite spirometry being normal, that these have very mild disease. Perhaps a better frame of reference is the R117H population, and this is the details, of course, of the randomized clinical trial, and this red line, unusually for ivacaftor trials, shows the ivacaftor treated patients 6 to 11 years old, and there was a significant reduction in lung function. Now, there are many explanations for this, but even in the continue study, you could see that the lung function in the first 12 weeks did not get above baseline. And indeed, when you look at the forest plot here on the right, quite clearly 6 to 11-year-old patients, the study favored placebo. And there is a suggestion for those people with very well preserved lung function also. And indeed, this has even formed national clinical recommendations, with recommendation against those 0 to 5-year-olds with R117H and against all those up to adulthood with FEV1 greater than 90%. So why the discrepancy? Could this be the degree of disease they had at the start? Well, I think that is certainly likely. If you look at the demographic table, you can see those patients who had very preserved lung function, 97.5% on average in the ivacaftor subgroup. But perhaps very importantly as well, 8 of the 17 participants in that age group had 7T in association with R117H. We'll talk more about this a little later. But the degree of disease was very mild, and actually this is very interesting in the context of R117H patients. If you look at the registry, they tend to actually, in comparison to patients with other mutations who lose lung function, they tend to accrue lung function in this early childhood period, and then a decrease is delayed but not absent. But could this also be the disease liability? And we've known for a long time that actually there are varying penetrance of some mutation. This is absence of the vas deferens, where the siblings of 131 patients with congenital absence of vas deferens related to CFTR gene mutations were evaluated for fertility, and only 7 had similar disease, which is 5 times less than you would expect if this was pure autosomal recessive inheritance with full penetrance. And this is very important when it comes to R117H, and this is a really important French study which looked at the clinical details of 184 patients who were compound heterozygotes for R117H7T, as it's the most common in France, and Delta F508. And they looked at the carrier screening tests they had performed additionally and identified over 5,000 patients. And so therefore, were able to discern what the prevalence of Delta F508 and R117H was in the French population. And with that information, the theoretical number of compound heterozygotes in the French population was estimated at 3,650. However, only 112 patients were known to have any symptoms related to CFTR dysfunction, and that includes CFTR-related disorders. We have penetrance of about 3.1%. So actually, if we were intervening very early in a number of patients carrying this mutation, potentially we would be overtreating 29 out of 30 patients. And it's not just R117H. Penetrance also affects a range of other mutations, including D1152H, which is far from 100% penetrance. And also very common mutations such as TG12T5, which is about 8 times as common in the general population as in CFTR2, TG11T5, another mutation of varying clinical consequence, is about 95 times more common in the population than seen in CFTR2. So if we're going to intervene in very mild disease just based on genotype, well then we need to open the gates for our clinic, because there are hundreds of people in the community that will need attention. And if we treat all those, we're probably treating within a window of futility. Indeed, G85E is another mutation with partial penetrance, and here Harel and colleagues looked at 3 siblings with CF, 1 with absence of vas deferens and 1 healthy, and that was entirely due to different mRNA expression in nasal epithelia. So one of the other things that we need to talk about is, can we actually measure disease so we can know that we need to intervene, or can we monitor or benefit effectively if there's no demonstrable benefit? Well, I would argue that we need to forgo some of the measures that are mandated by clinical trials, such as spirometry, and look at things like LCI, infant lung function, low-dose CTs, functional MRIs, all showing evidence of very early disease that we can detect, and all actually having evidence of response to CFTR modulator therapy. So I think we can be reassured by this. So early conclusions: organ failure, even if associated with mild lung disease, is not very mild disease. There's no evidence for modulation therapy early in people with milder genotypes. Varying penetrance would directly mean we would overtreat people and treat people who had not developed disease. And we can also detect early disease to prevent futile treatment, because we want to stay in the era of precision medicine where we're treating each individual and move away from things like use of unproven therapies as prophylaxis. Because if you're looking for evidence for CFTR modulator therapy in patients with no discernible benefit, well, the arguments would be we cannot measure benefit. Well, I've just outlined a number of techniques which I think we can very successfully measure benefit. And the other argument is that we will prevent disease progression. But if we want to do this, it needs to be safe, effective, minimize number needed to treat. It needs to be equitable and also cost effective. Looking at the safety profile of triple CFTR modulator therapy, well, we know it's quite safe in the short term. We just don't have long-term data, a decade, 2 decades down the line. I would also highlight the fact that actually we do see LFT abnormalities, 11% in the clinical trials, and significant raises. By that I mean 3, 5, and 8 times the upper limit of normal. Happened 1.5 times more commonly in triple therapy treated patients than those treated with placebo. So could it be effective as prophylaxis? Well, again, we have to really look at the ivacaftor picture. And this is a registry study published last year. And this is figures of the prevalence of diabetes in ivacaftor treated cohort versus comparator group that were matched 5 years on. And what you can see is ivacaftor patients actually have a greater frequency over time of diabetes. Comparator group similarly, but at a greater accrual rate, giving an absolute risk reduction with ivacaftor about 6.23%. Therefore, estimated numbers treat with ivacaftor to prevent 1 case of diabetes would be about 16. But can you imagine what that number would be in patients who are by and large pancreatic sufficient? It's going to be huge. And I argue that potentially there is an appropriate point at which we can intervene, when we can preserve lung function, get the benefits, but we do know that disease is attributable to CFTR dysfunction. This even can be seen in nebulized Dornase. This is a UKCF registry study looking at the long-term effects of Dornase alpha according to different subgroups divided by lung function. And you can see that lung function actually drops in those people with 100%, 80%, and it's only as you get into different lung function environments, and particularly lower lung function, that you see benefits with this therapy. And while I'm not suggesting by any stretch that CFTR modulator therapy should be delayed until you get moderate or even severe disease, I think it illustrates the point that perhaps there is a crucial time with which we can intervene. And that's important because these are expensive drugs, and no CFTR modulator therapy, I will remind you, has ever been shown to be cost effective. And this cost ineffectiveness will only be increased if we treat those who will not benefit from treatment. And that's important because if we provide CFTR CFTR modulator therapy to all that provide some degree of equality. But actually, we do need to tailor our approaches to ensure that those most in need get the most help, to have equal outcomes for all, because non-tailored approaches will lead to differential results. And that goes beyond CF in any resource-limited healthcare system, because we all want granny to be dancing and to have her hip replacement. And we know the resources are limited. And we actually even know that social inequality affects outcomes in CF, and that should be something that requires a lot of investment. And clearly medicating before needed is an unnecessary expense. So in conclusion, we actually can detect lung disease that will progress. We can monitor for benefit. The risk-benefit ratio is not favorable for those with no discernible benefit. And I think us as a community need to clearly personalize our approaches. I would like obviously to thank CF Foundation, the organizing committee and the chairs, but in particular, I would like to thank the fantastic team of people I work with in Manchester Adult Centre. Thank you, and I look forward to the panel discussion.